It's October 29th, 2021. This is the RheumNow podcast. Hi, I'm Dr. Jack Cush, executive editor of rheumnow.com. You know, bad things happen when our patients go into the ICU, and it's not always due to the disease. You know, good things happen when we rise from sitting. And guess what? Rheumatologists are setting cardiology straight about hydroxychloroquine and chloroquine. First, let's begin with a report from Annals of Rheumatic Disease. Baricitinib and long-term safety. You know, I usually don't pay much attention to these sort of reports because they always look good. That's why they publish them. But it's important given the current environment where the JACs are being told you need to have a boxed warning for these cardiovascular risks, the DVT risk, and these cancer risks. Well, let's just look at the patients who were entered into long-term safety and efficacy studies with RA and baricitinib, and they use different doses in these studies. 70 patients, almost 4,000 patients, almost 15,000 patient years. They report the incidence rates as per 100 patient years, and these numbers are good, meeting expectations, and certainly not falling outside of the norm. Serious infection rate of 2.6 per 100 patient years. That's really good. Herpes zoster rate of 3 per 100 patient years. That's 30 per 1,000 patient years. Again, that's about double the risk that we see in just RA patients on TNF inhibitors. So, but we've seen that before. That's expected. The MACE, the major adverse cardiovascular event risk, is 0.5. Interestingly, if you look at the MACE risk in the same kind of patients who are in the 1133 study with Pfizer, meaning over the age of 50 with one or more cardiovascular risk factors, the MACE rate went from 0.5 to 0.77 in the first 2 years, and then after that, settled down to 0.6. I don't know that that's a major risk. The cancer SIR was basically 1, with a standardized mortality rate of 0.74, meaning lower if you were on these drugs. And the DVT and PE risk, or VTE risk, is 0.5 or 0.4, respectively. Again, these are numbers that are falling in line. So how the Pfizer tofacitinib study is going to translate to a risk labeling for the drugs not studied in this population remains to be seen. So some COVID data this week that's kind of interesting. An Israeli study looked at the risk of breakthrough infections in their healthcare workers who were vaccinated, and they looked at almost 1,500 fully vaccinated, usually 2 of the Moderna, 2 of the Pfizer, whatever vaccines. They had 39 breakthrough infections for a breakthrough rate of 2.4%. Again, this happened between January and May of 2021. Of those that did have breakthrough infections, most of them were mild or asymptomatic. 20%, that would be about like 7 or 8 that had persistent symptoms that went on for more than 6 weeks. But in general, they did very well. Nobody was hospitalized. Nobody died. Those who got the breakthrough infections tended to have lower neutralizing antibodies. So it can occur, but if it does occur, you're better off if you've been vaccinated. I found this MMWR report from yesterday, 2 days ago, really interesting. It looked at the risk of a non-COVID death amongst people who were vaccinated against COVID-19. So number one, we do know, and you should be reporting to everyone you know, that receiving a COVID-19 vaccine is not associated with higher mortality rate. It's in fact not. But when you look at non-COVID deaths, a higher mortality rate from COVID, I should say. When you look at non-COVID deaths, you know, it's actually really quite low, significantly lower. So if you look at the risk of a non-COVID death and after receiving 2 full doses of the Pfizer COVID-19 vaccine, the risk was 0.3, relative risk 0.34, meaning a 66% lower risk. Moderna is 0.3, meaning a 69% lower risk of dying, and Janssen's 0.5 of 46% lower. So the idea is that getting vaccinated, you know, it may just be a surrogate marker for people who are healthier in their thinking. So interesting data. The ACR has published a white paper about the antimalarial cardiac toxicity story, hydroxychloroquine, Plaquenil, and all that cardiac stuff that we went, white papers. What is that? Is that a step up from white pages? A white paper is a position piece, an expert analysis, an official statement without necessarily being a guideline, a recommendation. I don't know. But anyway, a lot of people got together and worked on a very nice paper. And the paper reviews basically the rare risks of arrhythmias, conduction abnormalities, cardiomyopathy, the QTC issue, and torsade de pointe numbers are very low. And they did reinforce that there's no evidence that says that we should use routine ECG testing. Obviously, if people have symptoms or if they have a cardiac history, maybe a baseline EKG, but there's no need for ongoing testing. A nice report about short walks in between prolonged sitting. So they tested three different scenarios. People had prolonged sitting, not getting up, not doing nothing. Those who had 30 minutes of moderate to vigorous exercise a day, and those who had multiple 3-minute episodes of light walking every 3 minutes. Turns out that the vigorous exercise and the 3-minute light walks did very well as far as lowering cytokine levels, IL-1, and increasing IL-1RA, improved glucose, C-peptide, and insulin levels. There's a benefit to getting up and walking, even if those people can't get up, don't want to get up. Again, light walking, non-strenuous, 3 minutes every 30 minutes is the smart thing to do. Vasculitis patients who get admitted to the hospital. There's a study of 83 ANCA-associated vasculitides and 44, and these were admitted to the ICU, admitted to the hospital. 44, half of them died in the ICU, with the leading causes of death being infection or active vasculitis. Infection first, 61%, active vasculitis, 34%. 1/3, they died from the disease. 2/3, they died from an infection. I often assert that when our patients get admitted to the hospital, they're more likely to be in trouble from not the disease, but the consequences of the disease, meaning age, other comorbidities, drugs and drug complications, etc. Predictors of ICU death were the Apache score and evidence of respiratory failure. So this was also seen when you looked at lupus patients. So when lupus patients go into or when all rheumatic patients go into the ICU, it could be for a lot of different reasons. Turns out that lupus is the most common of rheumatic diagnoses that gets admitted to the ICU. And that, why do they get admitted? It's usually for sepsis. So again, of 80 patients admitted in this one study to the ICU, 42% for lupus, 26% for RA, 12% vasculitis. And again, sepsis was the big reason, 31%. CHF was about 10%. 20% died in the ICU. 5% died after the ICU. 7.5% died within 1 year. The overall mortality, should one of your patients go into the ICU, could be as high as 32% in the next year. Scary numbers. Taiwan looked at the risk of what happens when sepsis is seen with lupus. So they looked at hospitalized patients, over 800,000, and hospitalized for sepsis. If anyone in that cohort had a diagnosis of lupus, it increased the mortality risk threefold. And then after they made adjustments, it was still a 50% increased mortality. And this was higher than other factors known to influence sepsis mortality in the hospital, such as age, prednisone use, methotrexate, and immunosuppressive use. Finally, we saw the results of one of these sequential rituximab, belimumab studies. This is called the BEAT lupus study. We talked about this at EULAR. It was published this week in Annals of Internal Medicine. As you know, this is a small pilot study that had the strange primary endpoint of lowering double-stranded DNA titers. But it's a small study, 52 patients, and they were randomized to either receive rituximab followed by belimumab infusions, or rituximab followed by nothing, which would be placebo. And it turns out those who received the sequential rituximab belimumab had significant lowering of their double-stranded DNA titers by 70%, and they had a significant lowering of the risk of future severe flares of their lupus as measured by BILAG A. So will we see more of these? We talked about this before, the SynBio study. There was another study, I'm blanking on the name, from San Francisco that was complicated by background use of Cytoxan. But there's a number of these sequential use studies. Belimumab didn't works, a little bit in lupus. Some of you think a lot. I don't think so. Rituximab didn't work in lupus. Well, if you give rituximab, you get a rebound in BAFF, and maybe that's why you get flares after that, or why it doesn't work, which is maybe great rationale for giving the anti-BAFF drug belimumab. But we just have preliminary studies here. We need larger, well-controlled trials to make this a standard of care, even in your most difficult and refractory of lupus patients. Regenerative medicine, we might as well call it hocus pocus medicine. Stem cell injections with fat cells from someone's butt going into their shoulder. I'm sorry, this is shameful what we're seeing. There's a new report that was in JAMA this week about platelet-rich plasma, PRP, injections in ankle osteoarthritis. Is a 100-patient study. Why? Well, about 3 to 4% of adults have ankle or tibio-talar OA. Interestingly, ankle OA more commonly affects younger individuals. And there's not a lot you can do in younger individuals, right? I mean, you don't want to do surgery when they're 19, 20, 31. You'd like to have a non-interventional, non-surgical approach, and maybe that's why they're messing around with this. But this was a well-designed, blinded control trial. They either received PRP or placebo over a 26-week period, and both groups got better to the same degree, about 10, 11 points. Hence, there was no significance between the groups. Yet another regenerative trial that crashes and burns as they should. I think the big news for me this week was hearing from Pfizer and Lilly that they were pulling their nerve growth factor inhibitor called tanezumab. This follows in the footsteps of other companies that tried to get into this area, this therapeutic area, but backed out because there were a lot of problems with side effects and dysesthesias, but really rapid progression of osteoarthritis leading to joint replacement. These put those events, put those studies on hold. FDA had to have a hearing. They started back on the studies. And as you know, in March, the FDA had a hearing and they didn't do so well. The panel voted against approval of the drug, and this past month, the EMA, the CHMP, had a negative recommendation, a non-recommendation for approval to the EMA. So with this in mind, both Lilly and Pfizer, who are co-developing the drug, have backed out. And the problem here is that, first off, they should be applauded, spending 10 years and a lot of money trying to develop this drug, because in osteoarthritis, we have a tremendous unmet need. 54 million Americans. And what's your best therapy, by the way? Oh, yeah, acetaminophen. You're not allowed to use anything else, and joint injections don't work, and narcotics are a nay-nay. And my goodness, we need help here. It's sad that this has not worked out. So I want to end with a discussion of family history. I don't like family history. I think it's totally useless for almost everything. That's another discussion. I'm talking about like father, like daughter. I heard this week about one of our RheumNow faculty, Maral El-Ramahi. I met Ramal at the Cleveland Clinic during her fellowship. She's been a faculty reporter for RheumNow and done a fabulous job. I heard this week that her father died, Kamal El-Ramahi. Dr. El-Ramahi was a rheumatologist for a long time in Indiana, well known in his community, well respected by everyone, a great father-daughter pair of rheumatologists. I'm mesmerized by this thought. I read about Dr. Ramahi in his passing, and there was a great line in there that he was a man characterized by sacrifice, strength, love, charity, patience, dedication, integrity, and faith. I should hope that those words are used in my final days. Nothing about, prior authorizations and all the great medical things he did. It was about the man and what a man he was to his family, his friends, and his community. So it's always a sad thing when we lose a great rheumatologist. It's even sadder when it's a friend's family member. But I like the words, the apple doesn't fall too far from the tree. And Ramal has done well early on in her career, and she'll continue to do well. And it's great that she's had that guidance for so long. I looked up, who amongst us follows in the footsteps of their parents. I saw one study that said the careers where it most likely happens: steelworkers, bakers, lawyers, and yes, doctors. I'm glad my father wasn't a steelworker. Well, then I might have been like Rudy in the movie Rudy. That's another story. It is a wonderful thing, however, to follow in the footsteps of your parents. If I had followed in the footsteps of my parents, I'd be a stay-at-home dad. No, I'm only kidding. My parents were, my father was a teacher, my mother was a secretary. But I've always been envious of classmates of mine who had doctors as parents. I thought that they had a jump on me. I was late to the game. The party had started without me, whereas they seemed to have an advantage. They grew up in a medical household, and I did not. So I've had to work harder, but I always thought that was special. When you look at the numbers, you look at med school classes, 1 in 5 of med school students have a parent who's a doctor. If you look at medical school applicants and who gets in, if your father or your mother were a doctor, you have a 14% higher chance of getting into medical school. So is that, nepotism? Is this occupational inheritance, or is this just like-minded family members following into careers of passion, being passionate about the career? So I want to end with a like father, like son, like father, like daughter, like mother, like daughter. And there's a lot of us out there who have parents in the field of rheumatology, or you yourself are a parent. First one I met in my career when I was a fellow was Orrin Traum. He went into practice with his dad, Nathan, in Southern California. And they were together for a while before his dad passed away. One of my residents from Parkland, Dr. Yui Holt, went to Memphis to join his father in a rheumatologist in practice. We all know about Dr. Lenny Calabrese and Cassie Calabrese, now at the Cleveland Clinic, 2 great teachers and researchers. In my training in New York, I got to know Dr. Harry Spira, and later on his son, Dr. Robert Spira, at HHS in New York City. There's Dr. Manesh Jain and his father in Ravenswood, Illinois. There's a lot actually from Illinois. Eric Ruderman and his dad were rheumatologists. Bill Arnold and his daughter, Erin Arnold. I guess there's more. In the great state of Louisiana, there's my good friend Larry Broadwell and his son Aaron, most of you know. Dr. Lee Simon from Boston, his daughter went into rheumatology. That's Dr. Alexa Mira, and she's now in Ohio and doing very well. Dr. Shahida Kwayumi and her daughter Seema Frosh are both rheumatologists. Dr. Ann Takacs and her daughter Libby Ray. Dr. David and Megan Greenfield. Dr. Perry Rush and Rafi, also known as Raphael Rush in Canada, are good friends. Dr. Hassan Yaziki from Turkey did his training at special surgery in New York, and his son followed in his footsteps, our good friend Yusuf Yaziki. My buddy Sergio Schwartzman, also at HHS, and his daughter Monica went into rheumatology. Dr. WL and Kristen Griffin, Dr. David and Jennifer Neschel, Paul Plotz from the NIH, and his uncle Charlie Plotz from Brooklyn. Dr. Gary Sturba and his daughter Janet Rakovchik. Dr. Sari Aristi, and both of her parents are rheumatologists. Dr. Rachel Wolf, and both her parents are rheumatologists. Alan Baer's father was a rheumatologist. And brothers, Brian Dyke and David Dyke, all rheumatologists. Family is gigantically important in our lives. It should be first in our lives. Being in rheumatology is like being in a family. Imagine if your parent or your child were also a rheumatologist. Oh, what a wonderful world it would be.